This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 606, recorded on April 24th, 2020. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from Western Massachusetts, Alan Dove.
Good to be here. It's cloudy and rainy.
From Austin, Texas, Rich Condit.
Howdy. How's everybody?
Good.
91 degrees. So.
From Southeastern Michigan, Kathy Spindler.
Hi, everybody. It's kind of gray, but it's 54, so that's a lot warmer than it has been. That's Fahrenheit. And in Celsius, it's 14.
And not from a hospital parking lot, Daniel Griffin.
Hello, everyone.
Things must be getting a little better, no?
They are actually, and I think I'm gonna. I made a point of thinking about how I would talk about this today, and I'm going to conclude with a summary of good news. So, I think there are some positive things.
All right, I got everyone right?
Mm-hmm.
Yeah.
Okay, Daniel, go ahead, take it away.
All right. So for there's I think about 200 or 300 clinicians who get our Parasites Without Borders weekly newsletter, and it was titled last week, "Don't Just Do Something,
yes,
Stand There and Enroll Your Patients in a Clinical Trial." And this is a little bit of a spin on what people are probably, don't just stand there, do something. And I think that's gotten us into a little bit of trouble. So I'm going to be talking a little bit about what I'm going to say is perspective. I want to give people a little bit of perspective on how do physicians make decisions? And I know that a lot of people listening are physicians, but also I know a lot of people listening, actually probably the majority are not physicians. So I want to give someone a little bit of a perspective. So I'm going to tell a story that I think will get some sense of why physicians were acting the way they were acting early on. And it was actually about 3 weeks into this that one of the physicians that I work with, who'd been cross-trained to work in the ICU, was sharing this experience with me. And the story was this gentleman normally was in another specialty. And when the COVID epidemic started, there were a bunch of people who were basically at home waiting for them to be cross-trained to come in to cover for ICUs and the like. Basically, he was describing for me what for him was a very frustrating experience. He felt like here the world was on fire, but he was home. There was nothing he could do. And he felt like sort of a desperate need to, I want to do something. I want to make a difference. And then about 2 weeks after the pandemic was really up and running, this individual came in to cover as one of the ICU doctors. And the way we did this initially is they would work with one of the seasoned, experienced, board-certified intensivists. And then after a little bit of time, they would be given a little bit more sort of free scope, but always this constant, actually more communication than I've ever seen in the history of medicine, but lots of give and take communication. And he comes in on his first day, and those of us that have been there as it started, maybe we'd sort of been gradually getting used to this, but by 9 a.m. that first day, 4 of his patients have already died. And then the day doesn't get much better. And he relates to me that, at the end of his first day, in the trenches, in the ICU, with just such horrible numbers of people doing poorly, dying, he got home, got his car in the driveway, and basically just cried. It was just like, this was overwhelming. This was more than emotionally, than he was ready to handle. And it was interesting for me because while I was experiencing this myself on a daily basis, I would get phone calls, I would get questions, I would get emails, and they would always start with "I'm very anxious too," and then they would have some idea of what they were very anxious to do, what therapy they were anxious to give to their patients. And I initially did not understand where this was coming from. The world turned upside down. We don't give random things to people until we have a really well thought out idea on that it might make a difference, or we have evidence that it might make a difference. But I think after hearing this story from my colleague, I understood that there was a mixture of fear, was a mixture of people being overwhelmed. And I think there were a lot of physicians who really were desperate to make a difference. So I think a lot of maybe the things that were tried early on came out of these different scenarios. But I want to give, I think, patients, and maybe this also helps for doctors to rethink where do we get our therapeutic approaches from? What is the context? And those of you that have listened to TWiV for any time are probably aware with the idea that the ideal is the evidence-based practice, where there's a well-controlled trial. People are blinded. They're not sure if they're getting the therapy or a placebo. No one knows, that they can't mess with anything. And at the end of the day, the blinders all come off and we find out, was therapy A or therapy B or no therapy at all, what resulted in the best patient outcomes. And I have to say, when I started training, which I guess was last century, I was being reminded when I had a conversation this morning. I'm a little older than hopefully I look or sound. But no, I went to medical school the last century in the dark ages, when actually the concept of evidence-based medicine was still actually being introduced. And I still remember one sort of very annoyed senior physician who basically said, what are you trying to say, that one well-controlled study with a couple thousand people is more valuable than my years of experience? And we kind of looked and said, that's actually where, that's what we're saying. That's pretty much the deal. Your years of confirmation bias. And so we'll talk about, so when you go to see a doctor, what do they base their therapies on? And some of it is evidence-based, right? And that's the ideal. That's what we're after. That's what we were really moving towards at a rapid pace before the epidemic. Then there's something called evidence-based medicine. And this is, I think what we saw a lot of in recent weeks was where you find the oldest physician around with the highest title and you ask them to drop some guidelines, tell us what to do, because we don't want to do something wrong and we would love them to tell us. And so, this echoes what Mark Crislip, a fellow podcaster, likes to say, that the 3 most fearful words to ever hear on the wards is "in my experience." And some people say, what the mistake here was basically you were enlisting help from someone who is, quote unquote, making the same mistakes with increasing confidence over an impressive number of years. So we saw a little bit of movement in that direction. Then there was the vehemence-based medicine, where someone comes in and maybe they have a loud, forceful presence. They basically browbeat you into submission. Why would you think of doing that? So we saw a bit of that. We saw sort of the more confident, louder folks dictating care to the more timorous. We saw eloquence-based medicine, right? This is, spin over science. A well thought out, professed approach is better than, evidence, particularly when there is no evidence. Diffidence-based medicine, this is where you often say, doctor goes back and forth and says, quote unquote, no good answer here. And I always say, there may be no good answer, but there's certainly a lot of bad answers. So let's avoid those. And then there's the nervousness-based medicine. I think people are familiar with defensive medicine, right? The only bad test or therapy is the one that you forgot to give or order, right? And I think we saw a lot of I'm going to do everything because maybe one of those things is good. And maybe 90% of them are bad and harmful. But when the family calls me on the phone, and they do, and says, did you try A, B, C? When they go through the list, you can say, we've tried everything. And I am usually the person on the phone saying, no, we did not try everything. We tried what we thought would actually make your loved one better. But there was a lot of that. And then actually what we've been running into, and this I'm going to talk to as we go through sort of advice and what we're doing, is the concept of careful observation and experience-based medicine. This is where we are trying things, but always trying to say, what did that do? Did that help? Did it hurt? And some stuff you get really quick feedback in real time. Someone's on a ventilator and their oxygen level is in the 70s, and you turn up the oxygen, now it's in the 90s. That was sort of a pretty quick response. We saw this with the concept of proning. You'd have someone on the floor and their oxygen saturation would be dropping, and we'd lay them on their belly and it would go from the 80s into the 90s. So very quick responses. And we saw this with anticoagulation. We were seeing a lot of people having pulmonary emboli. When we started anticoagulation very quickly, instead of 8 a day, which is pretty impressive, we saw the numbers drop. But as we go through things, I'm going to use this context to talk about the advice and sort of how anxious and hopeful many of us are to get back to true evidence-based medicine, and how actually experience-based medicine can trick us. All right.
So that requires clinical trials, right?
So that is, and that is, not only is it key, but I'm going to talk about why it's key. And so I'll jump right to that. And I was talking to some of my colleagues this morning about something called the Merrick protocol, M-A-R-I-K. And this is where a lot of ideas about vitamin C came in the intensive care unit medicine. And the story was, there was a gentleman, Paul Merrick, and he was seeing in his intensive care unit really pretty bad outcomes. Basically, he was seeing 40% of the patients that he was taking care of were dying from the acute respiratory distress syndrome, the ARDS, sepsis that we were familiar with. And he watched that, and he basically recorded about 7 months of data and said, I've been seeing really bad outcomes, but I got a brilliant idea, and I'm going to try it. And then I'm going to just observe for the next 7 months and see. You can't do much worse than about half your patients dying. And so Paul Merrick, Dr. Merrick, started giving his patients all vitamin C, thiamine, and steroids. And at the end of the next 7 months, his mortality had dropped to 7%, right? So this is overwhelming, right? It was, quote unquote, a game changer, right? Everyone embraced the Merrick protocol. He became a sage of ICU medicine folks. Now, just in January, they published a trial because someone had the audacity to question this outcome and say, you know what? Why don't we actually do a controlled trial, multi-center? Let's enroll a couple hundred people. Let's see if getting the vitamin C, thiamine, and steroids is better than just the low-dose steroids that people have been doing. And let Vincent guess what the outcome was.
Didn't work.
Yeah, no difference. But if you ask an ICU doc, well, I'm sure that multi-center double, I'm sure that wasn't done right. I see some flaws in the methodology. I have much more faith in the sort of observation retrospective before after publication of Merrick. So it is interesting. It's very, and I worry about that. Actually, I bring this up because I worry about that in COVID, is that early on we were seeing horrible outcomes. And I'm going to talk a little bit about those studies that have now been published. We were actually seeing in the Northwell Hospital experience, right? So here's a whole bunch of hospitals. They just published 5,700 cases. How did people do? And of the 5,700 people that were admitted basically over the month of March, when they looked at these folks in early April, only about a third of them had even been discharged. The rest of them were still in the hospital. Of those that had ended up being ventilated, what percent were actually discharged alive by the time they did the study? 3%. Really pretty dismal, right? It makes the 7%, makes the 40% mortality that Merrick was seeing seem like nothing compared to a 96, 97% that we were seeing. As far as not getting them out alive. And that was actually what we were seeing when we first went in with the steroids and the TOSI. So I'll jump in on that. But in our initial experience, we went from a 3% up to a 21% getting people out and alive. So, for us, it seemed very compelling, but I still myself remember the Merrick experience, and that we were probably doing a lot of other things too. So it's hard to,
Yeah,
I don't want to.
There's some kind of almost like a physician placebo effect too. I mean, they're not blinded necessarily in this case when you're trying these things.
Yeah, that's true, because that's one thing they say you can never correct for, and that's why they blind us in trials. You can never correct for physician bias, right? Were you giving that treatment to the person that you thought, quote unquote, was going to die anyway? I think early on, actually, that was what was happening. A lot of treatments were being people were being enrolled in a trial because people were saying, well, I think they're going to die anyway. We might as well try something. Let's get them into, the remdesivir trial, the tocilizumab trial, the Regeneron IL-6 receptor trial. So yeah, that's always a bit of a challenge if you let the physicians decide which patients to try different therapies on without the blinding. So, all right. So let's get back to the outpatient experience and current recommendations, but hopefully with all these caveats in mind. So I think our outpatient experience, we've seen in the New York area, I think about 250,000 confirmed cases. And within the ProHealth network, we've seen, tens of thousands of cases. We get a lot of feedback, and the outpatient experience continues to reinforce the idea of the first week being milder, the second week being that critical week of decompensation. And actually, what we've seen at an increasing rate is end of second week, third week thromboembolic complications. So even in the outpatients, even in people that have not been sick enough to end up in the hospital, people have never gotten any treatment at all, we're still seeing a significant amount of usually venous clotting in that setting, but we're also seeing people end up in the emergency rooms with pulmonary emboli, strokes. So that is a growing issue, and there's a growing sort of discussion, I'm going to say, because we're not sure exactly where we go here, about the role of, whether it's anticoagulation, antiplatelet agents, something as minimal as an aspirin a day, or whether or not a person is at higher risk and might warrant something more aggressive. So the outpatient experience continues along the fact that a growing number of people, we realize, particularly when I talk about serologies, an incredible number of people never get sick enough to require hospitalization. So this is a huge number of people that need care. And one of the things I'm going to say here, and I think this is really critical, I talked a little bit last time about how many patients are showing up already with their appendix burst because they were afraid to get medical care. Here in the New York area, we've been overwhelmed. And we've been, I think, maybe not as quick as we should have been in getting telemedicine up, but for most of us, that's all up and running right now. And it's really critical. And this is something I think the ProHealth doctors all listen to, the TWiV for their weekly in-depth update. But really critical to get on the phone with your patients and let them know you're here, let them know they can reach out to you, because the last thing we want to see is someone showing up with a ruptured appendix, or they've already had a heart attack and they're quite ill before they actually are able to get in touch with a doc, get proper treatment, go to the emergency room or an urgent care center, or even an office if that's what they need. So I know some of the doctors were saying when we've talked to them, I feel kind of, like I'm drumming up business. Actually, please do drum up business. I'd much rather have our patients talking to their doctors over the phone or these video chats than showing up in the ER because they were afraid to come. So reach out to them because they want to know you're there, and we need them to know you're there so that they don't wait too long. We see less people, dying per day in our hospitals, but we're still seeing 200 to 300 people dying a day at home, and the acuity by the time they come to the hospital is quite something. So we keep encouraging our doctors, but sort of an encouragement to all doctors: let your patients know that they can get in touch with you, and you can take care of them, that they don't need to wait too long, so to speak.
Daniel, the clotting issue, does that happen only in people with ARDS or in anyone?
No, we're seeing this in patients that were never even sick enough to come to the hospital.
I see.
So we're seeing in the hospital, about 30 to 40% of the people that come into the hospital have evidence of some coagulation issues. Mm-hmm. And we're seeing a growing number of patients that call on the phone. I never was sick enough to even go to the hospital, but now my leg is all swollen and I've got this big clot in my leg. So it's across the board, and we don't quite understand what's driving it exactly. But
Daniel, you just touched on this, but I was wondering how these coagulation issues manifest in terms of symptoms. Stroke is pretty obvious. You mentioned pulmonary and venous. How does that show up?
Yeah, so we see venous and arterial clotting issues. So the venous is, the most classic would be a big clot in the lower veins of the legs and maybe getting into the upper veins of the legs. Sometimes those will break off and actually end up in the lungs.
And that shows up as swelling?
Well, so it'll either be when the patient notices it, it'll either be pain or swelling, or sometimes they'll actually be able, if it's superficial, they'll actually be able to feel this warm, red painful, tender area of clot, and we do ultrasound, you can actually see it filling the deeper veins. Some patients don't know. I think there's probably a lot more of this than we even realize, because a lot of the deep venous thromboses, the venous clotting, is asymptomatic.
And then the pulmonary, does that show up as pain or?
Yeah, so the pulmonary, we have central and peripheral. So the central ones, which are really quite impressive, often they're these saddle emboli where they really block the central supply to the lungs. Basically, what they're doing is they're coming through the right side of the heart, they're ending up in the lungs. And these will, if you look with an ultrasound, you could see basically the heart is struggling against this pressure. You'll see an increase in oxygen need, an increase in effort of breathing. And we actually do these CAT scans where we can see these huge clots. But there's also a lot of peripheral clotting that we've learned about from autopsies, unfortunately. And here, you'll actually sometimes the CAT scans will be able to read them well enough, and they'll basically say subsegmental thrombus being seen. Sometimes we can't see it, and it's a matter of seeing that the D-dimer is rising. The platelets are dropping down, the oxygen requirement is going up, and then once we're able to get them fully anticoagulated, the D-dimer will start going down, platelets will return, the breathing and oxygen requirements will improve. So, and
I'm wondering if you could update me on, from a patient's perspective, when is it time during the course of disease to contact your physician or go to the hospital?
Yeah, it's we have been I think saying now for a little while, and I think this keeps being reinforced, that it's really that second week that we worry the most about. And the older and more other issues you have, the earlier in that second week. But I like to get the physicians talking to the patients over the phone, and I'll talk to the patients over the phone myself. And really what I'm listening for is, does it sound like the patient is walking on a treadmill? Are they able to complete full sentences? Do they sound comfortable? When we do our telemedicine, we're actually counting respiratory rates, seeing like, are you breathing in the teens, which would be normal, or is your rate starting to get up in the 20s? So yeah, because so many people, right, are not going to end up in the hospital. Most people are going to get through that second week where they have some sort of peak period of shortness of breath, but not getting to this point where they can't complete a sentence. The other I should finish while we were talking about our clotting is arterial clots. And that would be some of our strokes would be where you're actually clotting off the arterial supply to a part of the brain. Or as we just had a patient this morning he's alert. He's not in ARDS. He's on a face mask oxygen, and basically said to the nurse, my right foot is cold and numb, and what's going on? And even though this man was on full anticoagulation, he had a big arterial clot, basically blocking off his leg. So we're trying to rapidly address this, because otherwise he's gonna lose his leg. So,
do you think any of the neurological symptoms are viral neurotropism, or are they all related to clotting, you think?
We don't know, actually. We don't know.
Okay.
Yeah. So it's, and I guess I'll throw in while you bring the neurological, I hope I didn't scare too many people about, but I was mentioning that we're seeing quite a bit of neurological complications. We're actually seeing a fair number of cases with a GBS. I don't know if no one can pronounce that properly for me. Guillain-Barré, thank you. And so these patients will suddenly become basically flaccid. It's as if they're paralyzed and quadriplegic. They have no reflexes. And, this was originally reported in China. There was another nice case series in the New England Journal. We've seen about half a dozen just over the last couple of weeks. The Irishman, who's doing quite well, actually developed this recently. And you treat them with intravenous immunoglobulins, so IVIG, and very quickly the strength and reflexes come back. So it's quite impressive. I mean, we believe it's IgG mediated because we're seeing it later in the course, but again, we're not quite sure. But they are responding to IVIG, standard therapy with IVIG. But the other is the neurological. I mentioned that we've been tolerating lower levels of oxygen to keep them off the ventilators, and you can imagine when success rate was only about 3% for getting folks, alive and back home after being intubated. There was a lot of a lot of pressure to do that. People tend to be tolerating this, and by the time they're ready to leave the hospital, they seem to be back at baseline. I was just going through with a number of the hospitalists, and basically encouraging them to pay a lot of attention to this. And it does not look like we're seeing a lot of permanent neurological impact. So that's very positive. Okay, so now hospital experience. So one of the big things, I don't know how people are familiar with this, but we've been trying to really limit the amount of patient contact. And we call it sort of bundled care, where you get your best person, so to speak, to do a really thorough physical exam. So we don't have everybody in and out of the room, infection issues, personal protection equipment issues. But a lot of what's really key here, and I think we've done a really good job, I have to say, the folks at Plainview Hospital, but not every hospital has the same resources and staff or experience, whatever you want to say. But charting is really critical. And so what we've been really trying to get everybody to do on a good level is, if a person is on nasal cannula oxygen, always making sure they document how many liters of oxygen are on the nasal cannula. We've been fortunate to have something called Venturi masks. So once a person is no longer getting the oxygen saturation you want with nasal cannula, we can use what are called Venturi masks, which allow you to dial the percent oxygen from about 24 up to 50 or 60% oxygen. And then you can actually see, okay, they're on 35, they're on 40%. It allows you to really track, where unfortunately at some medical centers, they go right to these face masks, and then you're not really sure the oxygen level. So that's been really helpful for us, is to have, a lot of this is nurses, excellent charting by the nurses, where they document nasal cannula, when they go to Venturi mask, if they're on the Venturi mask, what percent oxygen, and then if they're on the full face mask, the non-rebreather, charting on a regular basis, what is the oxygen saturation. So if it starts getting into the 80s, we know that we need to keep a closer eye on those. And so those hospitals not in the New York area that have a little time, maybe, I invest in Venturi masks, make sure the charting is really up to speed. That is super helpful. And then as far as interventions, and I'm going to do this in the context that we talked about, most people have stopped using, at least in our centers, the hydroxychloroquine during the second week. Doesn't seem to do much. Maybe it makes things a little worse if you look through the literature, but still some big trials looking at maybe it makes a difference in the first week, right? So there's a really nice study going on in England. There's the patch study, all the different arms that are going on here in the United States. So that's helpful. Azithromycin, most people have sort of stopped treating a viral illness with antibiotics. So that's sort of nice. Remdesivir, I think most of us have said, boy, they've been studying that for a long time and we're still not seeing anything compelling. A lot less interest in that. Plasma, I know people have gotten excited about this. One of my colleagues works at a hospital where they use actually quite a bit of it. And, his comment was that we're not seeing much of an impact. So we'll have to wait for the studies on that. But, I'm sure y'all can talk about the viral dynamics and such, but I'm not sure it's going to make a big difference. But we'll see. But we're not observing anything that's compelling, I should say. Steroids, right? We've got a few studies on that. We're really careful to say, this isn't a one size fits all. Not everybody who gets COVID, only a minority of people need steroids, or I should say it looks like there's a minority of patients that may benefit. But again, there are some studies probably better for this than anything else, but not the high quality studies we're really looking towards. And these are, these come with risk, right? You're suppressing someone's immune system while they're infected. And some of these people, if they end up on a ventilator, they're at high risk for other infections. Tocilizumab, I think I mentioned that there are some, I'm going to say, low quality experience publications out there. So we don't have the quality of data we would like.
Is that the IL-6 inhibitor?
Yeah, so tocilizumab is the IL-6 receptor inhibitor that Roche has on the market. There's also an IL-6 receptor inhibitor that Regeneron has been studying. There's a bunch of studies here. I think I mentioned our experience where we went from about a 3% success from the ventilators, getting them out into the world, to 21%. But again, these are small numbers, and we always worry about confirmation bias. And when you give a medicine like this, you're hamstringing the immune system. So you want to be careful about that. Also, I think the hospital charges $5,000 a dose, so it's not cheap. Cheap. I think it only costs $800 or $900 for them to get it. So there's maybe a markup there. You guys can talk about that. So the prone positioning, right? I was giving some of the docs a hard time in yesterday. What are you doing? That's not evidence-based. Like, yeah, but it works really well. And so it's actually pretty impressive. I mean, you take people who are laying on their back are not getting their oxygen levels up where you want, and you have them lay on their left side, they lay on their right side, they lay belly down. It's really impressive. So this is very, very quick. As you turn up the volume on your radio, and I know that's not evidence-based, but I'm pretty sure it gets louder. So yeah, we're seeing pretty quick feedback on that. I mentioned the permissive hypoxemia. Let's try to get less people on vents, and we're not seeing cognitive impact. So that's reassuring, I think, 'cause I was a bit worried about that. Hypercoagulability. I was mentioning that about 30 to 40% of inpatients may actually have coagulation issues. And we actually had the experience where I remember having the conversation when we were starting to see this and say, whoa, we got to put everyone on anticoagulation. And they said, well, let's look and see how many people actually have pulmonary emboli. And we documented 8 that day. And I said, okay, maybe we are going to start putting everyone on anticoagulation. And if anything, what we've started to do, and this is a change, is when we put people on anticoagulation, instead of just saying, oh, this is the dose, this is what it says on my little reference guide, we've actually been routinely monitoring the efficacy and finding that what was supposed to be the dose, the standard dose for low molecular weight heparin, is not actually getting us into the therapeutic zone. So we're doing these anti-factor 10A assays and actually realizing that we have to individualize the dosing. Sometimes we're using heparin drips, and sometimes we're actually using direct thrombin inhibitors. And then we're monitoring targets for the activated PTTs and actually looking like a slightly higher percent there. And when we do that, we're actually seeing D-dimers coming down, platelets coming up, oxygen requirements going down. But just to be honest, not 100% success here, but we're starting to, I think, fine tune this a little bit better. All right, serologies. So I don't know if you guys have been following this, but it was very exciting for us this week. Healthcare workers and everyone actually have been able to start getting serologies. Quest Labs started. You could go in with an order from your doctor and get your IgG level. And LabCorp is going to do this Monday. And the New York state started testing, doing these big surveys. And it's good and bad. The results are good and bad from our perspective. New York City, a little over 20% of the randomly, quote unquote, randomly sampled folks were positive. Out here on Long Island, it's about 17%. Statewide, it's about 14%. So random means it's not focused on healthcare workers or anything like it. Yeah. Truly random. Okay. Well, that's why I say quote unquote. You guys can talk about how random is anything.
As I understand it, that was published in the Journal of Andrew Cuomo's Twitter feed.
Yes, I'm quoting Andrew Cuomo's Twitter feed.
Yeah. So we have some questions about methods that I think are not going to be answered anytime soon.
Okay. Well, you guys, I'm going to leave that to you guys. But from our perspective, it was good and bad. One is they basically said, you know what, you instead of 260,000 cases that, we think we had in New York, you may actually have 2.6 million cases. So there may be a lot more folks that are actually positive than we know. The good perspective from, my perspective is that may mean the mortality, Dixon's always wants to know the mortality. The mortality of this disease may be closer to 1% instead of a 10%. So that this will be really interesting as we really pin down these numbers as the serology goes up. I got my serology test done.
What you got?
And?
What do you got?
Well, as I told my wife, how embarrassed would I be
if I was positive?
So, yeah. So here I am with all this exposure. I'm still negative.
Great.
Wow.
Yeah. So thank you. Yeah, I did it once through one of the local hospitals in a research study, and then I actually had Quest repeated as well. Yes, I am negative ×2, so I will continue to practice my my infection control obsession.
And these are not rapid tests. These are tube of blood quantitative.
Yeah, these are tube of blood quantitative IgG serology tests. So yeah, I guess I have to keep being careful.
Yes, you do.
And let me just finish off with a summary of good news. I'm not sure if that's good news that I'm still negative. Would be nice if I had it and not realized it was now, but it looks like not only does it look like the daily new case counts are now maybe stable or down, but it also looks like the daily deaths, at least in the New York area, may be on their way down. There's sort of a bounce that we're seeing a little bit here. But the hospital admissions are down for our system and for our area. The census levels, the number of folks in the hospital, are down. And not only that, the staff has really gotten pretty much to become COVID experts. So now I just worry about the fact that, hey, there's other things in the world. And we had an issue this morning where a poor young lady had aspiration pneumonia, and it took 2 negative PCRs before anyone would believe that this was a non-COVID case. So, so a reminder that as the COVID counts go down, there's still other stuff out there. We did not cure HIV, tuberculosis, aspiration pneumonia, or the many other maladies of humankind.
Indeed. All right. Daniel, I had a question from a listener who said, from your reports, he gets this impression there are two kinds of disease. There are people who die of viral infection, and there are people who die of ARDS and cytokine storm. Is that correct?
It seems to me it's really just the latter. I'm not sure that people are actually really dying from the virus, right? It seems like the first week during the viral replication kinetics, that folks are not that sick. They don't tend to get sick until you start seeing this inflammatory cascade. That's when we start ending up, seeing them in the hospital.
Do you have any sense for how much? So the early mild disease, virus in the upper tract. So does the more serious disease in some people correlate with virus going down into the lung, you think?
We don't know. We don't. I mean, one of the things that we would love to have more data on, and we've tried to actually get the lab to give us the QT values on the PCRs, because I don't want to just know positive, negative, right? I mean, this is like you asked about serology. I want to know what's the level, and so I want to know, is my qPCR coming up at cycle 15? When they say, oh, they're still positive at day 41, is it coming up at cycle 34? Because that's quite a bit different to me. I mean, one of the nice things, there was a couple studies, one of them where they showed, we were worried that, maybe if you give steroids, you're going to have prolonged viral shedding. Actually, they showed, no, it clears right about the same. So we're fortunately not seeing evidence that we're prolonging viral shedding into this second week. So we're thinking that the second week is still cytokine storm, ARDS, and that it's not direct viral impact.
Mm-hmm. Anyone else?
Yeah, I have one thing. Going back to something you said earlier, and this is just kind of a curiosity about what it's like to be a physician. My experience as a lab nerd is that when I would do a protocol first time around, it might be awful. Really, my first time I do a northern blot, it looks awful. And then a year later, after I've been doing northern blots for a while, they're beautiful. And if I try and think what I'm doing differently, I don't know what it is. And I've come to and that happens again and again and again. And I've come to the conclusion that it's probably just a matter of paying close enough attention so that you change a lot of little things. And you don't even know what they are, but it gets better. Your stories about, for example, the mortality on people on ventilators in the hospital reminds me of that. Is the same kind of thing going on? Changing a bunch of little stuff and you're hardly even aware of it or don't know what it is?
I think that's actually what, is sort of in my, we'll call it the Merrick reflections, is that I worry about that. We're clearly, we think that we're doing better. the number of admissions relative to number of discharge. We're seeing, a lot of people discharged. I looked over the numbers of the JAMA publication, like 4% of all the COVID admissions had come to our hospital, but over 10% of the discharges were from. So it looked like things were going in the right direction. But yeah, what exactly is it? What's in the secret sauce that we're doing? Because there's many components. The staff is more ready. The staff is more comfortable. The staff is doing a lot of different things. We're doing a lot of different things. And that's why you need these controlled studies to tell us what exactly is it that we're doing that makes a difference. But yeah, we're getting better and more comfortable with COVID. We're trying to, if anything, I look at the different centers and I say, we're actually doing quite a bit less now than we did early on. I mean, early on, right? Everyone got everything. And at the centers where everyone got everything, I'm not sure the outcomes were quite so good. Now we're doing a bit less. We've basically learned a number of things not to do. So we're moving more into the paradigm of, stand there, think about it. Let's really address this instead of this early on, which was let's just try everything and hope something works. So we've seen some changes there. I was going to take this moment just to say, please, I didn't understand where this came from, but this morning on our call, we were saying, please don't have your patients inject themselves with bleach or breathe in nebulized bleach. I think, Vincent, you were endorsing that. Was that? Sorry. But please don't do that. It's very easy to hurt people. Let's please not hurt them. As mentioned, most people are going to be just fine as long as we're not there messing.
I suppose you also do not want to shine UVC light on them, right?
Yeah, don't swallow any UV flashlights or it's just
and don't open up veins and arteries to shine the sunlight.
Yeah, no, we joke about that, but there was that brief period of time. I think Vincent kind of caught a tail of this, where the idea was we were going back to the medieval ages and we were going to bleed people of the bad, evil humors and then give them good, fresh, blood. Yeah, please
Scary
don't.
Scary times.
It is. Yeah, it is.
Daniel, thank you again.
Oh, thanks,
Daniel.
Yeah,
thanks, Daniel. It was great.
Thanks.
One thing I wanted to mention, and this is not TWiV material, but Daniel's saying you put patients on their belly, right, and they get more oxygen. I wonder if that would cure sleep apnea, right?
Yeah.
Might.
People sleep
But
on their
then
back
people have to stay on their belly.
Yeah, and people move around, I guess.
Yeah.
Okay. So we have one thing before we have our little snippets, mini snippets. Can there be a mini snippet? I guess so. So last time I ranted and some people complained. Some people liked it and some people complained. And one person said, you should explain why you're ranting. And, I have this idea that we've explained it before, but I understand that people don't go back and listen. So the two things I ranted about, one, how mutations are not impacting anything at this moment. And when we do have some evidence, we'll go back and revisit that. But I do think we have other things that are important to talk about. And the other, of course, is, this week I had like 20 people call me and ask me about various stories, that the virus came from a lab in some way. And, there is no, as Alan said last time, that's a political issue.
Yeah.
Where was I? I talked to someone. And they said it's just, I know. I was on this wonderful Zoom conference last night, organized by Columbia students. And one of the participants said, people just want to blame someone.
Yeah.
They don't want to know the structure of the virus or how it does this or that. They want to blame someone. And that's what's happening. They're blaming countries. So I don't see any evidence that it's any different. No. And so when we have some evidence, we will talk about it so we don't have to spend time, because we have lots of other interesting things to talk about. And this conference I just mentioned, this was so cool. So I get on, there are a bunch of students, Columbia students, right? It's some kind of organization, which I can't remember. There'll be a video in a few weeks and I'll post it. And who's there but George Gao, head of China CDC. Wow, oh my God. Cool. Oh my gosh. And he was in front of an official CDC logo and had two flags on either side of him. And he was way in the background. Like the camera was really far away. Right. And then just before we started, someone brought him a cup of tea. And I'm like, who's going to bring my cup of tea? It was very interesting. but I would say when it comes out, listen to it. So George Gao is a virologist, and we know him because he's an editor at PLOS Pathogens, right? Kathy and Rich, is that correct? And he's yelled at me a few times about reviews. So it's an interesting episode. Okay, so a couple of things that are interesting. One, and these are all preprints, but here's one. COVID-19 vaccine protects monkeys from SARS-CoV-2. So this is a study out of China where they grow the virus and inactivate it. It's old school.
Very old school. I love this. It's like the simplest possible vaccine. You grow it up, you inactivate it chemically, and see if it works.
And this would be the first. Actually, it's a little slower than the mRNA vaccine, right? Because you have to grow the virus in sufficient quantities. And so they inactivate it. They check it that it's inactivated, and they injected, I think, 4 non-human primates, rhesus macaques. And it's already been shown, and we have talked about this, I believe, that if you put the virus in the lung of these macaques, they have a COVID-19-like disease. So they gave them 3 shots intramuscularly. It's called PicoVac, by the way, which reminds me of the site that Alan used to.
Oh, yeah.
Pico Online, remember?
Yes.
PicoVac. And then they have a control group, of course, and they measure the antibodies, and then they challenge them. They put the virus intratracheally, which means you put a tube into the trachea, and you spray the virus in there. Or I should say spritz, right?
Yes.
And then the controls showed viral RNA copies in the pharynx, the chrism, and the lung. I don't know what a chrism is. Do you?
No.
I've never heard that word before.
How do you spell that?
Alan will Google it. CRISSUM. And they showed severe interstitial pneumonia. In the vaccinated macaques were protected against infection, very small histopathological changes in the lung, and they're protected. And of course, now you would not normally put the virus in the trachea, not in such a high dose, I guess. So that's promising.
Chrism is the area under the tail feathers of a bird.
Oh, interesting.
I don't know. I guess there's some. I'm not immediately finding a definition.
Interesting. Maybe they made a mistake and used the wrong word. That doesn't mean sternum, under the sternum.
Yeah, I don't know why you would phrase it that way. Anyway, they injected it into the trachea.
And these are protected. So presumably they're doing some toxicity studies, and they will then do a phase 1. Yeah. So this is an interesting side here. I was talking to my wife about preclinical, this is part of this work, is preclinical before clinical is going into people, right? And she said, in the preclinical phase, we call it toxicity studies. In humans, we call it safety studies.
Yes.
Okay.
I thought that was good. She said, for obvious reasons. Do I need to tell you? No, I said, you don't need to tell me.
It's like when you get an MRI and not a nuclear magnetic resonance test.
Yeah.
Right.
I don't know if you said where this is from, but Sinovac Biotech is the main thing, and then Key Laboratory in China and various other Chinese institutes. So,
yeah, it's interesting, but it won't be around till next year, of course, but it's making progress. And then the other study is a paper out of Yale University with many, many authors, a few of whom I recognize, like Kiko Iwasaki and Nathan Grubaugh. Saliva is more sensitive for SARS-CoV-2 detection in COVID-19 patients than nasopharyngeal swabs.
Now, this has to go through peer review, but this, if it works out, is great news.
Mm-hmm.
Yes, for many reasons, right?
Yeah.
Because it's easy to spit in a tube.
Doesn't require a swab.
No swab all the way up your nose. And as they say, often it makes you cough and sneeze, which sprays the healthcare worker.
Yeah.
And the swabs themselves are expensive. Actually, weeks ago, we tried to order some here in the lab, and they would not sell it to us.
Yeah, there have been several reports of those being limiting.
Yeah, they went the way of the toilet paper early on, apparently.
Yeah.
Yeah.
So this, they show in, I think, 122 patients, it's more sensitive than the nasopharyngeal swab. These are patients who had been positive by a nasopharyngeal swab. And they can also do, serial test. The problem with these swabs, as Daniel mentioned, is you go in and you're never sure you're getting the same kind of sample twice, right? So serial samples are not always reproducible. But here they showed serial samples were always positive in a positive person, as opposed to an NPT, which sometimes was negative. So that's very good too.
Yeah,
we did a paper with similar sorts, with a similar concept weeks ago, but I didn't really like sort of the data, the structure of the study, et cetera. But it indicated a similar phenomenon, and so this is good to see.
And then there's one last bit where they had, I think, two people who were negative for NPT, and they were positive in their saliva. So they're asymptomatically infected, and this picked it up. So I think this is promising. There are not a lot of patients, right? They have to do more to see if this is true for a bigger swath. But, if it works, I think, here's what I think what should be done. The U.S. government should pay for all these and send it to everybody. And at one time, in we're going to know who's positive in the whole country. That would be cool, right?
Be very useful.
However, of course, the 300 million
that would be a lot.
Tubes of spit coming somewhere would be a lot.
Yes.
You have to do local labs. But I can imagine drop boxes in your local town, barcoded saliva tubes and all that stuff. I think more realistically, this is just something that'll make it a whole lot easier to roll the test out. For sure.
To more sites.
And they also mentioned that in resource poor areas, this would be a lot easier than a nasopharyngeal swab, right?
Right. They mentioned, I think it was this paper, mentioned that it's consistent with, two other recent studies supporting the efficacy of saliva. So if somebody does a meta-analysis at some point, that could be good.
I had meant to ask Daniel about what he thought of this, but we'll do it next time.
Yeah.
Also, people should know that Vincent wrote a blog post about this, so it's a nice, concise summary of it if you want to check that out.
Kathy at 6 a.m. wrote to me and said, you said that the nasopharyngeal swab was comforting to the patient.
All right. No,
actually,
it's discomforting.
I didn't notice it, but someone had noted it in the comments, and I noticed that.
Gosh, I can't believe I did that. Well, it happens.
Yes.
Okay, so that's good. That's saliva. Oh, one thing I wanted to say about that, and here I will not rant. I will just explain calmly. So the way they do PCR on these saliva samples, right? And they can calculate the number of copies of RNA per mil, right? That's fine. But they call it the virus titer. And I just think that's inappropriate and misleading, and they shouldn't do that because the virus titer is an infectivity assay.
The paper's not peer-reviewed yet. This is one of the things that can be fixed.
I hope it is, but these things are not always fixed.
Yeah.
But so that's my one thing. And the other is that I was thinking, well, what do you call it? Well, you can't even say genome copies per mil because you're not necessarily detecting a genome, right?
Right.
Detecting
Could
a little piece
fragments.
of RNA.
Yeah.
So the reason I want it to be clear is that, the press is going to say, oh, the virus titer was higher with the saliva assay. And that's not right. Was that a good non-ranting?
That was a good one.
Yeah, that was good. It's almost like you need a specific term that just says, it even gets people used to the idea of some sort of number from a PCR. I mean, we talk about QT. It's not obvious to everybody what that means, but it's almost like you have to come up with a new number that really reflects what's being measured, but that people can deal with.
What does QT mean, Rich?
Actually, it's the number of cycles in the PCR machine before you get what you decide to call a positive result.
This is how high you had to turn
signal.
the volume up before you heard the sound. Yeah.
Yeah.
What's a cycle, Rich?
Oh, God, you going to make me do this? Actually, I'm not sure I'm any good at this. Okay. You have to.
It's one round of amplification.
Round of amplification. Okay.
So you add your primers, you denature well, if this is RNA, let's assume we've already made DNA, right?
Mm-hmm.
Right.
You denature the DNA in the presence of the primers and the enzymes, and then you bring the temperature down to a temperature where the enzyme will work. You let it copy for a while, and then you heat it to denature, and then that's a cycle, right?
Yeah.
Right.
So
and
you can go
at each cycle, you are getting more of your product.
Right.
Okay. So QT is the actually, what is it formally?
quantitative, right? Quantitative real time.
At any rate, it is the number of cycles before you get a signal that you judge as being positive. So the deceiving thing is the lower the number, the more nucleic acid was there initially.
Right.
So low number means higher, if we want to translate it, virus load. Okay, though.
Right. So
Higher
if
template.
you only had to amplify 15 times to detect the virus, then there must have been a lot of copies of RNA to begin with. If you had to amplify 35 times to detect the virus, then that there had to be, and it's not a linear amplification. It's growing geometrically. It's, PCR copies each copy, which becomes more copies to copy. So if you had to go 35 cycles, then that's very, very little RNA at the start.
So what can we call it? You said template. Not, Kathy, could it be RNA copies per mil? Would that be a good number? A good name for it?
I don't know. I think sometimes people actually standardize it to some housekeeping gene, and you can end up having arbitrary units. So, yeah, there's lots of ways to display it, as it were.
Okay. All right. So I wanted to talk just briefly about these antibody tests that are starting to roll in, right? Daniel mentioned these.
Yeah.
So according to Cuomo, what did you call it? The Cuomo
Journal? The Journal of Governor Cuomo's Twitter published these results. And this is not a peer-reviewed source, and it lacks a lot of detail.
Yeah. So like 1 in 5 people tested have antibodies. And it varies between New York City, Long Island, Westchester, and then upstate, I think is the lowest, 3%. So I don't know what it means, because I would like to see the data, right, before we make any conclusions. But if you go to the article, there's a Times article, they have a epi curve for New York State, and it looks like it's going down. Do you guys see that?
Yeah.
Yep.
So maybe it is. We'll see when it goes down further. And then the FDA has a nice article about the caveats, on these antibody tests.
Mm-hmm.
And I think it's, like don't use an antibody test to diagnose infection, right?
Right.
Mm-hmm.
You can't do that. You shouldn't do that. Here's a very interesting part. Be aware that not all marketed serological tests have been evaluated by the FDA. They have a page where they list the approved ones. So do you think the approved ones are more likely to work better?
They've at least been evaluated by somebody outside the company.
Right.
Yeah.
And this is an emergency use authorization. This is not full FDA approval, with all the requirements of that. This is the FDA looked at the data and said, okay, this will pass for now.
Now, Rich, last week you may remember that you, like in the middle of the TWiV, you stuck in this California antibody survey, right?
Yeah, that paper dropped while we were recording.
Boy, did we get hell for talking about that.
What?
One guy wrote, and this is your friend. I mean, he's not your friend, your friend from Michigan, University of Michigan. He said, you guys blew it. But there's an article here from Wired, which basically is criticizing these two. So there was that one, which was Santa Clara, right, Rich?
Mm-hmm.
Yes.
And then there was an LA study.
Right.
And
that overlapped in authorship, apparently, with the Santa Clara study.
So the Wired article, 2 preprints offer surprising estimates of the infection rate and have caused a Twitter peer review uproar. So now things are peer reviewed on Twitter.
Yes. Well, they're going to be published there, so why not?
So the point here, one of the points is that it's not really a random population. Like a lot of them are solicited on Facebook, the people who are participating in this.
Okay, yeah.
And people who are maybe already sick and they want to find out what's going on and that sort of thing. So that's not how you do a properly designed Sera survey, right?
Right.
Sure.
So we understand the caveats there. So we will wait for a properly designed survey, which is done by epidemiologists. And they say, how many people do we need to have this properly powered, which means it will give us results that are statistically significant, right?
Yeah.
And what population should we sample to, like in New York City, what should we sample to get an idea of the whole city? You're not going to just do Fort Washington neighborhood. You have to go all over the place, right? And that takes time to design that. So that's what we mean.
Yeah. To me, it was exciting to see something. Mm-hmm. Okay. It wasn't 90%. Okay. It wasn't 50%. And beyond that, there's a lot to quibble about. There's a lot about
and I
the
think
tests, the sampling, the numbers, etc.
And the notion of the main quibble that I would have with this is the notion of extrapolating from this to what proportion of the county was therefore infected, and that you can't do that.
Right.
But it is very interesting that they went and selected people who had not been tested and went and tested them and found there were quite a few of them who'd been infected.
Yeah.
And this is consistent, importantly, this is consistent with other studies that we're seeing. There's the aircraft carrier where they found out there were a whole bunch of people who actually had it and were asymptomatic. There's the homeless shelter in Boston that I think I mentioned on last week's episode, where they took because anybody who was symptomatic in the homeless system got sent to one of the hospitals or one of the isolated shelters. They took this whole group that was in one of the regular shelters who none of them had symptoms, and 36% of them were PCR positive.
Mm-hmm.
Now, again, it's not a random sample, but it's very interesting that over a third of these people just had the virus. So what this is all pointing to is there's a lot of asymptomatic, or if you prefer, pre-symptomatic infection going on, and it's out there, and we're starting to see the scope of it.
Yeah, I think that's good news because, more people are infected than we think, and we need to get that number up for herd immunity purposes.
Right.
And yes, we need much larger studies that are truly randomized with tests that we're completely confident in.
Right.
So next week, we're going to have Jeff Shaman on, who's an epidemiologist here at Columbia, and he has published a paper in Science, estimating using some math methods. I say math, to estimate the number of asymptomatic people. So we can ask him all about this stuff.
Didn't we have him on?
That's right up. We did.
Yeah,
a long time ago. So we will do that next week.
Great.
One of the things, so I had a discussion about this morning with Amy, and she pointed out to me that if you're antibody positive, it actually just means you've been exposed, not necessarily infected.
Yes.
Mm-hmm.
Right? Because you could get, the example I give is you get an inactivated virus vaccine that doesn't replicate, you make antibodies, right? So if you get a exposure but no infection, you would still make an antibody response. And now we have an email from Charles who points out that it's hard to estimate the mortality ratio from the antibodies, right? So he says, they're saying the mortality rate is lower than we think, and that's really good. But his point is that the deaths are rolling, right?
Yes.
People, as Daniel said, people take a long time to die. So you can't take the deaths at any point in time and relate it to an antibody survey.
Right.
It's not appropriate, right?
Mm-hmm.
And I think that's a reasonable issue. So he says, bottom line, New York antibody study does not change the 1% estimated mortality rate models have been using. I wish it was really good news, but it's not. But we can ask Jeff about that next week.
Yeah.
And finally, he says, what's the difference between an introverted scientist and an extroverted scientist? Does anyone know? An extroverted scientist will stare at your feet. That's pretty good, right?
Good.
Mhm.
That's not bad.
Did you see the Tony Fauci T-shirt?
No.
In Fauci, we
There's
trust. Yeah.
Oh,
In Fauci, we trust. I'm going to get one.
okay. That's good.
I think it's really nice.
Oh, yeah. Yeah.
I should make one where that has TWiV on the back, right?
Yeah.
People are going to buy this. I really think that's sent by Anthony. Thank you.
I saw a video that was lyrics set to, I think it was the Officer Krupke song. What does that come from?
West Side Story?
Guys and Dolls?
West Side Story or Guys and Dolls?
Maybe it's West Side Story. At any rate, it was all about Fauci. It was really good.
I want to just point listeners to the latest TWiV, where Nels and I this past week talked about a couple of studies showing that the furin cleavage site in the spike glycoprotein of SARS-CoV-2 is not needed for replication in vervet monkey cells.
Okay.
So they find when they pass the virus in the SARS-CoV-2 in vervet monkey cells, which are kidney cells, they the furin site is lost, basically. It doesn't want it there for some reason.
Wow.
And an independent study has done the same thing with a pseudotype, a VSV with the spike from SARS-CoV-2. They take out the furin site and it's fine. Now, these are not human cells, so caveat emptor. Is that the right thing to say, caveat emptor?
I can't remember. Does the SARS-1 have that furin site?
No, it does not.
Okay, so that's why we're interested in it. Okay.
Yeah.
And the closest bat SARS-CoV does not have it either.
Okay.
Yeah. Is that right?
I think that's right. Yeah, I think because we've discussed how the furin cleavage site may be a key to infectivity of this virus.
Anyway, that'll be up soon. Maybe not by Sunday because Nels had a lot of noise in his room and I can't get rid of it. So I have to have Ray Ortega help me.
Yay, Ray to the rescue.
I don't know how to he's got some furnace running in the background. I can't get rid of it. Do you have some snippets you want to tell us about, Kathy?
Sure. Just a couple of things. I was on a completely different kind of Zoom call yesterday and realized that I had totally missed the fact that the White House had put out federal guidelines for when to open, and they describe 3 phases. And I had seen this Rockefeller supported, Harvard organized roadmap that Vi Hart did a blog post about, and Vi Hart is somebody I picked a long time ago when we did picks of the week. And I think the pick was for Pi Day or something like that. But anyway, she does these sort of whiteboard explanations. Anyway, she explains the 4 phases of this roadmap that these people put together, this consortium. And she said at the beginning, it's got Republicans and Democrats and conservative and liberal people and people from all different kinds of things. And in the end, we all agreed on this. So I think it's worth looking at the roadmap. I put in her blog post where she's got the transcript of what's in the video explainer. If the video explainer drives you crazy because of watching the animations or listening to her. But I think the beginning where she's showing the graphs is worth watching, at least that far into it.
Okay, good.
And cool. Then 538.com has this cartoon model of why it's so difficult to do pandemic modeling. And they basically just describe why all the parts of the modeling, we just don't know the numbers well enough. And so I thought that was really, really useful. Yesterday, I listened to, during lunch, an annual reviews sponsored webinar with Jean-Laurent Casanova, who's at the Rockefeller. And he's a person who's done things looking at human susceptibility to infectious disease. And basically, he described these monogenic inborn errors of immunity, and that's the kinds of things that they're looking for. So there can be these things that end up being deficiencies in lymphocytes and giving you the bubble boy or something like that. Or there can be errors or single nucleotide polymorphisms. Maybe not everything's a mutant. Nucleotide changes that can lead to just a sort of Achilles heel for one infectious disease.
Right.
And so what he's put together is a global consortium where they're going to be looking at the 5% of the serious COVID-19 patients whose serious disease is not explained by age or comorbidities. So basically, they have a cutoff of, it's going to be people under 50 and with no other comorbidities, but they end up, in pretty serious shape on ventilators or whatever. And looking at their genomes. And so far, they've got 100 enrolled in Paris, and they have 50 of those exomes or genomes sequenced, and fewer in New York, but they're making progress. And so that's going to be really cool because they'll have data from all around the world.
Good.
And maybe find some important genetic susceptibilities.
We have talked about some of his work on susceptibility to herpes encephalitis, I believe, in the past.
Mm-hmm.
Rich, are you still there?
I'm still here.
All right. I just want to make sure.
I am listening in rapt attention.
Because we could go on, for the whole thing, and you'd be gone. That wouldn't be appropriate.
No, right.
So then you have this paper that we were supposed to talk about a year ago. No.
A week ago. Only seems like a year.
Yeah.
This was one that I saw because I saw a review article that had a really nice figure of all the different targets for antivirals. And this one was specifically looking at targeting TMPRSS2, which is this protease that's important for infectivity of the SARS coronavirus because it helps to cleave the spike protein. And so what they did in this paper, and this is including Christian Drosten, and the final author is Stefan Perlman, who he mentioned, Christian mentioned in his podcast. And the first author is Hoffman, and I don't know if it's a sole first author. Anyway, it's published in Cell. And they look at the SARS coronavirus 2 and also SARS 1 S proteins, spike proteins. And they demonstrate here that the SARS-CoV-2 uses the ACE2 receptor for entry, which I think we kind of knew from preprints and other things, but this is the nice peer-reviewed paper about that. And that SARS-2 also uses this serine protease TMPRSS2. And what's interesting is that they use an inhibitor of that, and that inhibitor is already approved for clinical use, and it blocked entry, and so might constitute a treatment option.
What is this TMPRSS2 inhibitor approved for? What is it used for?
Oh, that I don't recall. And I don't even remember its name.
Yeah, I haven't read the paper yet, I will admit.
Yeah. Yeah. Let's see.
Looks like some kinds of cancers.
Okay.
But yeah, it's in clinical trials for SARS-CoV-2.
Okay.
By the way, it's interesting. It's a membrane-bound protease.
Mm-hmm.
And it's also responsible for cleavage of the influenza virus HA, which is also needed for fusion and infectivity.
Right.
And we did that paper of Perlman's a long time ago on TWiV.
Mm-hmm. Yeah, it has a really nice graphical abstract. I remember that now. When I first saw this paper, I didn't have time to read the paper, but I understood the graphical abstract. So that was exciting.
It'll be interesting to see if there's side effects because, it is a cell target, right?
Sure.
Right.
I noticed I didn't say toxicity.
Right.
Right.
Right. And
this volunteer thing, man. Is that what you're on to next? I'm sorry, I might have.
Volunteer thing. I was looking at the ACE2 is an interferon
ISG.
stimulated gene. Yeah. So that one.
Yeah. So that means interferon turns up the levels of ACE2.
Right. Right.
Which to me is not intuitively clear because ACE2 is involved in, maintenance of, what is the word? Your blood pressure. There's a better word than that, right?
But blood pressure describes it for 95% of us.
So I don't know why interferon would crank it up.
Well,
so I said to Kathy this morning, what is everything in ISG? And she said, no, Udell said 5% of the genome is ISGs.
Yep. I double checked what I had written down.
Makes sense because you need to protect against virus infection.
Yeah.
Right?
So that if this virus is doing that, or that, the interferon is doing that, it could, it suggests that the coronavirus 2 is exploiting this and
Well, of course, it's not exploiting, but it has evolved. It was selected to replicate when on high levels of ACE2, which is caused by the interferon response.
Right.
That would be quite interesting.
Yeah. So, and then the very last thing is something that American Society for Microbiology put in their newsletter that I got this morning, that Science is reporting that some good lawmakers are supporting the idea that the United States should allow volunteers to be infected with coronavirus to test vaccines. And this is important because we need to have sort of controlled challenge trials, perhaps at some point. And so that's what this is about. So that the link is to the Science article.
I really don't see how we can do challenge trials with a virus that is very serious in 20% of the recipients, right?
Oh, I thought it was more like 5%.
No, I mean, 80% are mild and 20% are more serious, right? And a good fraction of those require hospitalization. So I don't think you can have any test that requires hospitalization. The human viruses that we use for challenge, rhinoviruses, and then polio and influenza viruses in immunized people only. They're not
the 20% figure, though. If you select by age group, I think you get a much lower figure.
But still,
it is I'm with you on this. Is a virus with very, very serious risks and can have horrible outcomes, including death, even in people who are young and healthy.
Yes. So you could pick 20 to 30-year-olds and some of them would die. And then you could only license it in 20 to 30-year-olds. So what's the point? This is being proposed by lawmakers who know nothing about vaccine trials.
Well, actually, one of the people, one of the
lawmakers
spearheaded
Donna Shalala. No, this is it's important to realize this is a legislative effort that would allow the FDA to consider this. That's all.
Mm-hmm.
Okay,
and then that would leave it in the FDA's court, where there are people who are well versed in the science and the risk to look at this.
I just don't get it. I don't. So why we have to do this? Why risk killing people? I mean, can you imagine if a vaccine trial killed a few people? Who would take the bloody vaccine? It's crazy to even allow it. I mean, we don't do this for any other virus.
Right, we don't, but no other virus has shut down the world in recent.
Well, we've shut down the world. Actually.
Well, okay, but it has necessitated shutting down the world. I can see the public policy reason for allowing the FDA to consider this. I agree with you that this would be a really dangerous way to go. I mean, the argument for it is that it could drastically speed development of a vaccine.
Well, I would say that that's not actually true, because right now we have vaccines that have to go through phase 1, right? And then you do a phase 2, which requires there to be circulating virus, and there's still circulating virus.
True.
And it probably will be in the fall. So I don't know that this accelerates it any more than a month.
There's circulating virus, but what are you going to do? Are you going to vaccinate people in the phase 2 and tell them to deliberately try and go out and expose themselves to the virus?
No, of course, you never do that in a vaccine trial. You always counsel them not to get infected.
Right, so you're going to wait for people to get infected while simultaneously telling them not to.
That's how they do it for HIV vaccine.
Right, but
trials.
you need...
They counsel that you have to use safe sex condoms, and then they always get people who get...
And those trials go on for years. because you have to get enough people infected in order to actually get statistics that you can rely on. Whereas if you do a challenge trial, you can get results in a couple of weeks.
Yeah.
But yes, it's at a huge risk, and the volunteers would have to be well aware of that. And I hope it doesn't come to this.
Let's have a vaccinology person comment on this, not Donna Shalala, okay? And hopefully the people at the FDA are, I mean, I have contacts there. I could ask them what they think of this if they off the record.
Right.
Because I think this is just horrific. It's just horrific. And people are dying left and right, and they want to challenge. This is crazy. Because you have to have a control group, right?
Yeah.
Who are not going to get vaccinated.
Well, it depends on how you structure the trial. You could potentially get a quick answer here without having a control group.
But you are not in support of this, right?
No, I'm not in support of this. I just understand why legislatively it might be appropriate for Congress to tell the FDA, you can consider this.
Yeah.
And then by the time the FDA is even making this decision, it'll be months from now, and hopefully it'll be a moot point.
Right. Okay.
Just for the record, the other headliner on this move is a gentleman named Bill Foster, who's a representative from Illinois, who, yes, he's not a public health type, but he's got a PhD in physics from Harvard and spent a lot of time in industry. So he at least is trained in critical thinking.
Yeah, I have a friend who was with him in graduate school who said he's the smartest person he's ever met.
Yeah.
How can you justify infecting people with this virus? That is being dumb. I'm sorry.
Okay.
You could be physics smart. That's great. But I think he's being practically dumb. I know a lot of people would volunteer for this, right? That's fine.
Yeah.
Because they want to get protected, but I don't think you should do it. We're changing the fundamental tenets of public health by doing this. But okay, fine. Let's hear what people think.
Sure.
And I don't think it's a good idea. Kathy, can you take Barbie?
Sure. Barbie wrote and said, we are currently providing language editing services of SARS-CoV-2 manuscripts at no charge. And she wrote in response to the fact that I was complaining about finding manuscript reviewers. And she said, can't help you with that. But we are helping with editing SARS-CoV-2 manuscripts at no charge. We perform 2 rounds of editing on each manuscript. The first round focuses on grammar. And during the second round, we compare figures to descriptions and improve the overall flow. They adhere to confidentiality standards and have been in business with a loyal group of customers for over 13 years.
Cool.
So I'm not sure if we'll just put the link or something in the show notes if people want to check that out.
She points out that their expertise is in immunology, but that they also edit a fair amount of virology papers.
Right.
Mm-hmm.
So,
Okay. Alan, can you take the next
Sure.
one?
Catherine writes, okay, so this is regarding the most recent Trump rally, press conference. Please let us know how you feel about President Trump, who only yesterday appointed a former Labradoodle breeder as the head of the Health and Human Services Coronavirus Task Force, going on national television and suggesting that doctors ought to be shining powerful ultraviolet lights inside sick people and then injecting them with bleach. Sound medical practice or cutting-edge research? Inquiring minds want to know. Well, we're not supposed to rant. He didn't say exactly those things, but I did read the whole quote, and it's really, really, really stupid. Just the suggestion that you could use disinfectants to treat a viral infection, or somehow get ultraviolet light inside people to treat the infection. Don't do this. Don't just. To be clear, apparently we have to say now that you should not take disinfectants internally.
I think Daniel kind of alluded to this earlier.
Yes, this is...
So this is based on a Department of Defense study where they looked at, effects of heat, humidity, UVA, and UVC.
Right.
Which you don't get from the sun, right?
No.
You mainly get AM.
No, in fact, the UVC is the reason we need the ozone layer. So UVC is stopped. This is in decreasing wavelength. UVA is black light. up to UVB, which is the UV that gives you most of your sunburn. UVC, unless you've been to space, you have not had natural UVC. There are UVC lights available, and it is vicious stuff. It would, glance into it and you've got permanent eye damage type of thing.
So I just don't want people to think they can take bleach or somehow get UVC into you. Don't do that.
By the way, I did a quick search and I discovered you can buy UVC lamps, and I think they have a standard Edison bulb base on them, which is, you could just order these online, which is a terrifying thought.
Oh, don't put them in your light socket.
No. They're for very specialized disinfection use with protective equipment, and don't aim it at anything you care about.
So we occasionally face criticism for political comments of one sort or another, but this individual is asking specifically how we feel about President Trump and how we feel about this particular circumstance. And so I want to take this opportunity to say that I personally think that in particular in this realm, he's incompetent. And I think the best thing to do is to ignore him, okay, for the sake of your own health, okay, and rely on individuals such as Tony Fauci and others who we know the science and can advise people appropriately.
Okay, so Justin sent the same article to us, and then we have an interesting question from Dennis, who wants to know, how does a family protect themselves from a family member who is sick? So you're in a house and one person is sick. How do you protect the others? He said, is the blade as positive pressure, like the blade opening a bedroom window, taping off doors? I'm living alone, so I don't have to worry. I'm thinking of my friends. Good stuff you folks do. He's been listening for 2 months and lives in Miami, where our mayor is opening parks, even though there are more than 10,000 infected. This is a tough question, right? What do you do if you have an infected person in your family who's confirmed SARS-CoV-2 and is not sick enough to be in the hospital? So, the best thing is for them to stay in one room, right?
Yeah.
Mm-hmm.
But not everyone has that luxury, I guess. If you're all in the same room, which can happen, I would say you have to wear face masks, right?
Yeah.
Yeah, and there's a lot of hand washing that goes on.
Yes.
And you could
actually, my wife and I have a plan for this, because we have a guest room, and I've got my office, and so if either one of us gets sick, and the office is next to the guest room, and there's a John in between, so we're pretty well set up.
That's good.
But if either of us gets sick, doesn't matter which one, I'm moving to the guest room and using the guest bathroom and using my office. And I won't venture very far from there.
Good. We can get
I don't know how we're going to deal with the kitchen. The well person, I suppose, will use the kitchen and serve the other individual, and there'll be a lot of disinfection and hand washing that goes on in between.
Yeah, and this is something that I think would have to be developed on a case by case family basis. You know, if you have a house with a bunch of young kids and some youngish, 20-something parents, and then granddad is living there, it might actually make more sense to put, if one of the kids gets sick, put granddad in a separate room. Because, maybe you're just not going to be able to isolate the kid as effectively.
Exactly, yeah.
So you isolate either the person who's sick or the person who's at highest risk. And as Vincent pointed out, people are going to have different housing situations, and it's going to be harder in a lot of settings. But yeah, tough situation.
Yeah, there's a lot of stories like this in the New York Times. There was a story, I think it was on NPR this morning, about two individuals, one who's an emergency room doc and the other one, I think, is a social worker or something, and they come home and they never see each other. They talk by FaceTime. And they're not even suspecting that they're infected. They just are being careful.
Yeah.
So, yeah.
That could work for me.
So,
Rich, can you take Michael's?
Michael, hi, cool TWiV. I have been listening to your podcast for the last 5 weeks and enjoying them very much. It's so nice to hear intelligent, no-nonsense, informed conversation. It's been reported that here in the UK that there is a slightly higher rate of deaths from COVID-19 in the Black and ethnic community. Could this be due to low levels of vitamin D? Regards, Michael. I think that there is, unfortunately, a higher incidence of various comorbidities in some minority communities. But there's also other issues, at least I don't know about in the UK, but here, involving both testing and access to healthcare, and all of these things work together to impact on the impact of COVID-19 on those minority communities. It's a complicated issue.
As a rule of thumb, if there is a disparity in health outcomes between different racial groups in any society, the null hypothesis is structural racism. If in the U.S. we're seeing the same thing, the death rate is much, much higher in Black communities than in white communities, and it is well known and well documented that all sorts of, as Rich pointed out, comorbidities are much more common in the Black community. There's a whole history of how, fundamentally racist a lot of our health system has been. The legacy of the Tuskegee syphilis trial, which you can Google and read a whole horrific history, has still echoed through this. African Americans are much more reluctant than many other groups to seek medical attention, and that's not irrational necessarily. They're also reluctant to call the police because that's a rational concern. So anytime you see something like this, I would not reach for an explanation like vitamin D as a first level. I would say, well, have we looked at all the other factors that go along with this that are strictly social factors? I think that probably explains.
And when we say stuff like that, there's a higher level of comorbidities in these populations. That's not saying that there's a genetic or race component to those comorbidities. That itself is a reflection of access to healthcare.
Exactly. It's access to healthcare. It's access to nutritious food. It's access to money. There's just a whole hassle of stuff that goes along with being in the favored versus the disfavored class in a society that leads someone to be much healthier or much less healthy through no fault of their own, and not through genetics.
The panel I was on last night had what did he call himself? A social public health. He was a professor at Columbia. And he said there's also, this community has to do a lot of the work, the essential work that during this period they get exposed and there are more cases and so forth.
An excellent point.
Part of it as well. Kathy, can you take CZs?
Sure. CZ is somebody interested in science literacy and science communication, and writes, my question is about the vaccine that just started to be tried on human volunteers probably today. And it looks like the 24th of April being today. That might be right. The vaccine was developed in under 3 months by a team at Oxford University. Sarah Gilbert, who is professor of vaccinology at the Jenner Institute, led the preclinical research. And she says that she personally has a high degree of confidence in the vaccine. So she basically stated to the Times of London that she is 80% confident that the vaccine would work. And I found that quote in here. She says she hopes for an 80% success rate, which might be different.
Yes.
Anyway, they also hoped for about 1 million doses that could be ready by September. What do we know about this vaccine, and can we expect it to be available by September? So it's based on the chimpanzee adenovirus, and that's the one that I think we first became aware of as being listed in a set of vaccine trials as being originating in China. And so it's, with the spike is the antigen, and what else do we know about it?
So it's
described.
Some other,
so it's an adenovirus that expresses the SARS-CoV-2 spike protein.
Right.
So this is a technology that's been used before in trials, right?
Mm-hmm.
I don't think there's a licensed ad-vectored vaccine, right?
No, I don't think so.
No, not that I know
So I think it has as good a chance as anything else to work,
Sure.
right?
Right. I would say a good as chance as anything else, which doesn't necessarily mean a whole lot. Okay. I'm not real optimistic about there being a vaccine anytime soon. There's just so many problems to confront with constructing a vaccine. So I'm not putting my money on there being a vaccine. It would be great, and I'm really happy that a lot of people are trying. But there's so many of these things that look great on paper and just don't pan out.
How many successful coronavirus vaccines do we have already?
Yeah.
Look, people have been trying to make an RSV vaccine for decades.
Right.
And there's one failure after another.
I'm very sorry.
Okay.
There's one experimental MERS corona vaccine for camels, though, not for people.
So what I found in this article says that there will be 10 participants who will receive 2 doses of the experimental vaccine 4 weeks apart. So we're not talking big sample sizes either.
Well, this is a phase 1.
This is a phase 1, right?
It's a phase 1.
Yeah.
Right. And there's another thing where there's half of the 1,100 volunteers will receive a potential vaccine. So there's, I'm
1,100.
Actually, you can find this on. I've got the link here to the clinicaltrials.gov. Okay, and we might want to put this link in the show notes. Estimated enrollment is 1,112 volunteers.
So this is more than a
months.
phase 1, right? This is more than
they call it phase 1/2.
Okay.
Right.
So this is
phase 1/2 study to determine efficacy, safety, and immunogenicity of this particular vaccine in UK healthy adult volunteers.
So this is I'm assuming that this vaccine platform has already been tested and found safe with other antigens on it.
Oh yeah. It's been used a lot for HIV vaccine trials.
So
they say here in this in the WHO summary of vaccines and clinical evaluation that the same platform has been used for MERS, influenza, TB, chikungunya, Zika, meningitis B, and plague.
Right.
And I assume that that's all preclinical studies.
Yeah.
I don't know that there are any other even phase 1 or phase 2 trials with those vaccines, but it's a well-studied platform.
And I realize now with the 10 participants, they will get 2 doses of the vaccine. And the other 1,100, half of the 1,100 will receive the potential vaccine, and the other half of the 1,100, the control.
So it's estimated primary completion date, May 2021. So not tomorrow.
Yeah. Okay. I was the ad vectors I'm thinking about are not chimpanzee. They're 26 based. They've been in people.
Yeah. Yeah. And I thought I saw an ad 5 one. So this is potentially different from the one that I was thinking of earlier.
Okay.
Yeah.
So I'm got so many resources going on here that I'm looking at this draft landscape of the COVID-19 vaccine candidates that the World Health Organization puts out. And I'm looking at an April 23rd draft. Did I get that from one of you, or was that from?
That was from your
Brighton collaboration.
Yeah, Brighton, right.
So I think you can find this as a link. I'll look for that. But I can also just send this to you guys so that you can see. This gets updated all the time.
Yeah.
I'll look for a link.
Cool.
Alan, can you take the next one?
Sure. Betsy writes, says on my local NPR She's in Chicago. This is on my local NPR affiliate. A guy from Harvard was asked about the possibility that SARS-CoV-2 could lie dormant and resurface every now and then, like herpes or Hep C. His answer was basically, we don't really know, and I'm curious whether you all know if there's any evidence of this being the case. That sounds like no fun at all. Thanks for consistently presenting such a complex topic in a way that even I, an opera-singing, skydiving MBA, can understand. And Betsy, please tell us that you do at least 2 of those things simultaneously. Preferably involving Wagner with the opera singing and skydiving. But so persistent infection reactivation, I'm skeptical of that in a coronavirus, but I like the answer, we don't really know.
Yeah, the coronaviruses are not establishing latent or persistent infections. That's another kind of virus family. Even the hepatitis C, as she says, does that. But not these viruses. There's zero evidence for it, so I don't think this would be any different, right?
Yeah, I mean, it is true that we don't really know, but it seems like an unlikely scenario.
Yeah.
There's no evidence for it until there's evidence.
Until there's evidence for it, yes.
One thing I've noticed in this outbreak is people bring up all these possibilities that we have no evidence for, but they worry about it. And like this being a persistent latent, I don't know why you'd worry about it until there is evidence.
Well,
right?
It's because there's so much uncertainty about everything right now. And so everybody is looking around at, well, how bad could this be? And that's not a productive framing of the question, I think, because how bad could this be? Well, it could be awful, and it already is. I think it's better to stick with what's most likely to happen, and that's not comfortable because we don't like dealing in these ambiguous categories and probabilities, but it seems unlikely that this is going to be a persistent infection.
So I pasted in right above Betsy's letter. I pasted in this link.
Okay.
That I believe I believe that link should give you access to the regular updates of this World Health Organization draft landscape documents. You have to click through this, but it's great because it's got everything I talked about. Plus, in each case, where there's clinical trials, it's got an active link to the actual clinical trial at clinicaltrials.gov so that you can see it.
Good job, whoever's doing this at the WHO. Thank you.
Oh, yeah.
So Stephanie wants to know, is there any evidence that those with existing blood clotting disorders are at higher risk for blood clots while infected? So
I don't know the answer to that, but
Daniel didn't mention it, right? But we should probably ask him next time.
Yep.
Blood clotting disorders. So that means you get clots more than normal, right? And so you're on anticoagulants.
You're treated with anticoagulants.
Yeah, so that's a good question.
The question, Stephanie, is what would you recommend to those with these problems? And I would recommend not catching this virus, but I mean, more seriously, I think this is a question for an MD and for the MD who's treating this person in particular.
Yes, if you get sick, you tell your doctor, I have this. And
and in fact, one practical recommendation I would make for folks like this is to have a low threshold for calling your doctor. So a lot of, like if I develop a cough and feel like I might have gotten this, I'm not going to go pestering my doctor unless I think it's bad. If I had some history like this, I'd probably pester my doctor as soon as I developed a cough.
Yeah. Like Daniel said, don't wait.
Right.
Can we get just through these OPVs because we started?
Yeah.
Yeah.
So I think we can skip down this section.
We have a series of questions related to Kostya Chumakov's TWiV this week from number of people like, let's see. But Rich, it's your turn. Why don't you tackle a few of these?
Okay. Jennifer writes. Actually, before we start, I confess that I did not listen to that TWiV.
It's all right.
Yet.
What was his bottom line? Yet.
So he thinks OPV may provide nonspecific protection against SARS-CoV-2 because there's good evidence from studies of his parents in the Soviet Union and others more recently that OPV will give you 3 to 4 months protection against other respiratory and gastrointestinal viruses. And the mechanism is not clear. It's obviously not specific, but it may involve innate immune mechanisms.
And what was the conclusion about interferon?
Well, he thinks it's involved,
right,
but he thinks there may be something else as well.
Yeah. Okay.
Right. I think that's a big component of it. Yeah. Mm-hmm. So he wants to do a clinical trial for OPV2 in healthcare workers, basically. So I connected him with Daniel, and
that ought to be easy to set up. I mean, there's plenty of OPV, especially now that they suspended the eradication effort, and it's cheap. And
the thing is that he wants to use bivalent, which is types 1 and 3. So it does not have OPV2, which is an issue because then it reverts and gets into the population and causes outbreaks. Well, you should listen to the podcast because he's really interesting.
Mm-hmm.
So Jennifer, in her email, says, it occurs to me that in the last year or so, a number of folks born during or after 1957 got the MMR vaccine because they may never have received it as a child and because measles recently reappeared. Question: would it be helpful for science purposes to look at youngish seniors who recently took the MMR series versus those who did not? And there are plenty who did not, and see if the recent MMR might have provided some protection against SARS-CoV-2. Similarly, is there a place where people recently received the polio vaccine, and would it be helpful to look at the numbers there too? I don't know about measles or the MMR vaccine.
He said it might. He said it might provide similar nonspecific protection.
So sure. I mean, what we're saying here is if there's some reasonable possibility for this, then yes, you need to collect an appropriate population of people who did or did not get vaccines and do the numbers on them.
But the people here in the U.S. who would have gotten the polio vaccine would have gotten the inactivated vaccine.
Yeah, it's true.
So
I got recently.
Yeah.
Recently. It has to be recent. Right. It has to be in the last 3 to 4 months. Otherwise, you're not going to see anything. Yeah.
Right. Okay.
And actually, that's a good internal control, right?
Mm-hmm.
Yeah.
You can see when you got the vaccine. So yes, I think that would be interesting. As long as you can eliminate other confounding variables, which is not easy. I like that Jennifer signs a nerd in her own kind of way. God bless the nerds, she says. Kathy, can you do Ted?
Sure. Ted writes, also about TWiV 604. Let me ask a few naive questions about Zostavax, which I believe is an attenuated virus product meant to convey immunity against shingles. Mightn't this possibly do the same sort of thing? And might there be data in existence that bear on this? Since unlike OPV, Zostavax has been administered to large numbers of elderly people in the U.S. and perhaps elsewhere in recent years. Might it be possible to determine whether people who got it in New York City, for example, are doing better with regard to COVID-19 controlling as best as possible for other factors? Would it be a good idea in taking medical histories of patients with COVID-19 to take note of whether and when they have gotten recent immunizations? Yellow fever also comes to mind, and which? And is this already being done?
I think these are all reasonable, right?
Mm-hmm.
Yeah.
Although I don't know, Zostavax probably not being used much anymore because Shingrix, right, is replacing it.
Right.
Yep.
But still, these are pretty easy things. If someone comes in with COVID diagnosed, you could just say, what's your immunization history, right?
Yeah.
I think that's a really good idea.
Yeah.
And the same one as the next one is about flu mist. It could be also flu mist, the attenuated flu vaccine, right? Good. Right. Yeah, sure. Alan, can you summarize some of Kostya's responses?
Right. So also another one that came in for Kostya was wondering if the OPV link is possibly why India still has such a low amount of mortality. Kostya's reply says, indeed, that may be the case. Similar hypothesis was offered for explain lower COVID-19 incidence in countries with BCG. but it's also possible there's a higher prevalence of viral and bacterial infections in these same countries that continuously train innate immunity, and provides an example of polio eradication in Indian provinces of Bihar and Uttar Pradesh. The seroconversion rate after a dose of OPV was very low, and they had to repeat dosages, likely because people there had chronic intestinal diarrhea.
Yeah.
So, and I would point out another explanation for lower numbers in countries where OPV and BCG are used is that those countries are overwhelmingly poorer countries that are less well equipped to test for SARS-CoV-2.
Mm-hmm.
So it may be that the lower numbers we're seeing are just because they're not testing as much.
Yep.
That's certainly the case throughout sub-Saharan Africa, with the possible exception of South Africa. And I would expect that to be the case throughout India as well.
This points out nicely, though, that if you're thinking about just doing some sort of a survey about people's immunization status and whether or not they get COVID-2, that this is likely to be, could very well be a very complicated situation.
Yes.
Sorting out all the variables would take a pretty sophisticated statistical analysis.
This is why you need to do the clinical trial that Kostya was suggesting.
Exactly.
That you take a population where you know what's going on with them, right, and then you give or don't give OPV, and then you monitor, and they've got known exposures, and you need to do the controlled study.
Then here's John's question about flu mist, which Kostya apparently answered. This is probably true for flu mist as well. There's a 2018 study from South Korea that claims that flu mist protects against respiratory syncytial virus, a completely unrelated pathogen. Inactivated flu vaccine did not have this effect. Would be important to expand these observations to humans. Oh, that was mice. Sorry, the South Korea study is mice.
Still,
if anyone at MedImmune or AstraZeneca, as they are now called, is listening, they may want to consider this. Yeah, those are Kostya's answers.
Got it. Okay.
And so there's one more, Rich, from David Spector that Kostya answered.
Right. David Spector says, do you think recent infections with other viruses could produce a similar effect? Might explain some of the variability in people's responses to SARS-CoV-2. If we knew that, would it identify another cohort of people among these groups, such as healthcare workers, where such information could be useful in predicting who is more likely to be protected? Is it worth doing studies to find out? And Kostya says, all good points. And he basically agrees with all those ideas.
That should do it for this TWiV. It's number 606. You can find it on any podcast player. And please subscribe so you get every episode and we know how many people are listening. You can find all the show notes. That means all the letters, full text of letters at microbe.tv/TWiV. If you like what we do, consider supporting us, microbe.tv/contribute. And of course, questions and comments, go to TWiV at microbe.tv. Daniel Griffin, who was up earlier, he is at Columbia University Irving Medical Center, parasiteswithoutborders.com. Kathy Spindler's at the University of Michigan in Ann Arbor. Thank you, Kathy.
Thanks. This is a lot of fun.
Rich Condit is an emeritus professor, University of Florida, Gainesville, currently residing in Austin, Texas. Thank you, Rich.
Sure enough, always a good time.
Alan Dove's at turbidplaque.com. Alan Dove on Twitter. Thank you, Alan.
Thank you. It's always a pleasure.
I am Vincent Raccaniello. You can find me at virology.blog. I'd like to thank ASV and ASM for their support of TWiV and Ronald Jenkins for the music. This episode of TWiV was recorded, edited, and posted by me, Vincent Raccaniello. You've been listening to This Week in Virology. Thanks for joining us. We'll be back next week. Another TWiV is viral.